Assalamu alaikum everyone. It's my pleasure today to talk about ocular emergency, and this is important lecture for every GB doctors, every emergency doctor, and even for residents. So today our talk will be about ocular emergency. Okay. A practical approach to recognition, initial management, and ophthalmology referral. So in this lecture, we will know about what GB doctor should be able to do. Should recognize the vision-threatening ocular emergencies, perform a focused eye assessment, and identify conditions requiring immediate ophthalmology consultation, start appropriate first aid and emergency treatment without causing harm, know which common intervention shouldn't be performed by an ophthalmologist. And the first thing, every GB should ask about what? This problem, it starts since when? It's sudden or gradual. It's painful or it's painless. It's affected one eye or both eye. If there is any history of a trauma and if there is any chemical exposure. Always we should ask about contact lens, especially the most two common problem with contact lens. Number one is corneal abrasion, and number two, acanthamoeba keratitis or corneal ulcer. And we should ask about if there is recent ocular surgery and in the history if there is any intravitreal injection. We should ask about if the patient see flashes of light, floaters, or curtain-like appearance coming over the eye. We should ask about if there is headache, especially if associated with nausea or vomiting, and ask about neurological symptoms. The most important neurological symptoms I would like to hear about it, if there is diplopia, if there is loss of visual field, and if there is severe headache, especially with nausea and vomiting, to rule out increased intracranial pressure when we examine if there is papilloedema or not. And we should ask about a previous eye disease, especially like glaucoma. Okay, now the examination. What every GB should examine. The most important thing, every GB should know how to examine the visual acuity, especially in each eye. And how we can examine the visual acuity only in emergency room, and we didn't have any chart. We should know if the patient can see the counting finger or not, and at which distance. Like if you call me and you told me he can see the counting finger at a 30 centimeter, or he can see counting finger at 3 meter, or at the room distance, is different for me as ophthalmologist. Or he can see only hand motion, or he can see only light perception, or there is no light perception at all. The second thing, and most of the emergency doctor miss it a lot, the pupil. If the pupil size is the same in the both eye, if there is any zocoria or not, and how we will assess the relative afferent pupillary defect rapid. Now we will talk about rapid. Number three, the eye movement. If there is restriction, if there is pain when he moves the eye, if there is diplopia when he moves the eye or not. And external examination. About external examination, what we should know, if there is proptosis or ptosis, or there is lid swelling, if there is chemosis or laceration. Here, look at this picture. When I ask any doctor if there is rapid or not, everyone should know. When you want to assess the pupil, you bring your torch, your mobile phone, you put the light at the pupil and look. If there is, always we should look about three things in the pupil. Always we call it RRR. What is RRR? It's round, regular, and response. Is this pupil is round in shape or it's not round? If it's regular in shape or irregular, and its response to the light, or there is no any response to the light. If you look at the second picture here at the pupil here, you can see normal response to the light. Both pupils are constrict to the light when he put the light on the left eye. But when he put the light to the right eye, the pupil is dilated. And this is what we call it rapid, relative afferent pupillar defect. There is a problem in the afferent pathway of the vision. So any afferent pupillary defect means there is defect in the afferent fibers of the visual pathway due to optic neuritis or central retinal artery occlusion or other causes. Okay, it's very important to know the pupil is constrict to the light or not constrict at the all. About visual acuity. Okay, here the first exam, the counting finger. He can see one finger, two finger at 30 cm, 1 meter, 3 meter at the room distance, or he can see the finger at all. Many doctors call me, doctor, the patient have loss of vision. Did he see the finger? Yes. How it's loss of vision and he can counting finger at the room distance. But if he didn't see the fingers, I will go for the second exam, hand movement, especially at 30 centimeter from the patient. Tell me, my hand is move or not at all. Okay, this is how we can assess the visual acuity in the emergency room. We should examine if there is red eye, and this red eye, it's diffuse in all of the conjunctival injection or only around the cornea. We call it ciliary injection, and it's associated with corneal opacity or hypopyon or not. This is by outside look. I will classify the ocular emergency to immediate life-threatening vision. This is very life-threatening cases. We should refer it to ophthalmology as soon as possible. And the second classification, and there is third and fourth. I will just mention them, then we will go in detail in each case by case. So the immediate vision threatening, if there is chemical burn, this is very emergency. If there is rupture globe, open globe, if there is acute angle occlusion glaucoma or central retinal artery occlusion, these are emergency ophthalmology and it's immediate ophthalmology referral. It's as soon as possible. We will talk about each case now, case by case. The urgent in the same day, it should be seen within 24 hours. If there is retinal detachment, corneal ulcer, hyphema, significant trauma, or orbital cellulitis, this is within 24 hours. Same day ophthalmology referral, we call it. Number 3, it's urgent but usually stable. If it should be seen within 48 hours, if not in the same day, we can see it in the second day. Corneal foreign body, corneal abrasion, post-operative inflammation, post-cataract or post-refractive surgery. Usually primary care manageable. Any emergency doctor can deal with it, especially like conjunctivitis, corneal abrasion, subconjunctival hemorrhage, blepharitis, or chalazion. First case, chemical eye injury. There is a 32-year-old worker present 10 minutes after cement pounder entered his eye. He has severe pain, photophobia, and blepharospasm. I want to ask which chemical eye injury you know. Dr. Abdurrahman, do you know type of chemical eye injury?
Chemical eye injury, you mean by chemicals, by substances like chemicals?
Yes, we have two types. We call it the alkali chemical eye injury and acid chemical eye injury. Which one is more dangerous on the eye, the acid or alkali?
Alkaline, I think.
Yes, alkaline. Alkaline always, it's very dangerous because it's lead to penetrating the ocular tissue. And if there is history of any alkali chemical eye injury, the emergency doctor should start the treatment. And the treatment always copious irrigation immediately. Mostly we use 1 liter of normal saline or ringal lactate. Or if there is no ringal lactate, no saline, you can use tap water, better than delaying irrigation. There is one study talk about if the emergency doctor start the irrigation as soon as possible, the complication of the eye, it will decrease about 75%. So the most important factor influence the prognosis is reducing the duration of the chemical exposure to the eye. But any chemical eye injury, it's urgent referral to ophthalmology. Let us look at the picture. Here, this is severe chemical eye injury. You can see here the whitening and the edematous at the cornea. You can see the severe injected of the conjunctiva. Even you can see the chemical injury at the eyelid and around the eye. When you see this case, start irrigation as soon as possible, then call the ophthalmology. I start irrigation, please come to see the patient as soon as possible. This is urgent case. Case number 2, suspected open globe, rupture globe we call it. Typical case, patient come to the emergency, struck in the eye by high-speed metallic object. Vision has suddenly decreased and the pupil is irregular. So always look at the pupil. It's round, regular, and there is response to the light. Here in rupture globe, it's not round, not regular, and there is no response to the light. So the red flags, mostly it's penetrating injury. The pupil is peaked or irregular. Always there is uveal prolapse. What is uveal prolapse? The uveal tract, it's the iris and the ciliary body and the choroid. So mostly you will see iris prolapse. The anterior chamber, it's shallow and associated with severe subconjunctival hemorrhage and sudden visual loss. Mostly here he can't see the counting finger, and even the hand motion he can't see it, some of these patients. Here, look at this picture. You can see the iris prolapse. You can see the iris, it's coming from the cornea outside, severe injected of the eye, and you will see the eye collapse because the fluid sometimes it's go out. But here, due to the iris, it's closed the wound, but you can see this is a rupture globe and it's an urgent case. What you should do as emergency doctor, rigid eye shield. Don't patch the eye here. This is very important. We have shield. It's a transparent shield. You can put it at the eye without touching the eye and keep it, the patient, NBO. Try to control pain and nausea, but also ask about tetanus assessment, and it's an urgent ophthalmology consultation. If you can ask for CT orbit to rule out intraocular foreign body, it will be something great. Okay, and don't press on the eye. Don't try to measure the intraocular pressure. We can always measure the intraocular pressure in emergency room by digitally. We put the finger at the eye and see the globe is soft or rigid or hard. But in these cases, don't try to measure the intraocular pressure. Don't perform forceful lid traction. Try to see under the eyelid or something. Don't do anything. Don't remove an embedded foreign body, because if you press the eye, maybe all of the fluid from the eye go out and the eye is collapsed. Because sometimes we see all the uveal tract, it go out, it prolapse because someone tried to press over the eye. Don't patch the eye with a pressure patch. This is very important thing. Okay, now I will put some pictures, and I like activity. If anyone like to share with us, it's my pleasure. But here I will explain this picture. In the first picture, you can see here peaked pupil. Okay, you can see here. I want to draw it. The pupil is peaked. So the pupil is not round. Okay, it's not regular. And even if you check if there is response to light, you will not see the good response to light. The pupil not constrict. And here there is rupture globe. It's difficult, but when you see this shape of the pupil, here the iris is go, the wound is small here and it's open, the eye is open and the iris try to go outside, so the pupil is peaked. So here there is rupture globe, the eye is open, and this is the irregular peaked pupil due to rupture globe. Here another case of rupture globe. You can see the pupil. Let's go to this side. It's not round, not regular, and you can see the iris tissue is go outside here. If you see, this is the iris tissue. Okay, it's go outside the eye. So this is iris prolapse here, rupture globe. It's an emergency case. In case number 3, this is due to trauma. You can see the hyphema. There is no rupture globe, but when you see also hyphema, it's an urgent case due to severe trauma to the eye. You should call the ophthalmology. We will talk about hyphema now. In this case, I put this picture because here there is corneal abrasion, but this corneal abrasion is due to chemical injury. It's large abrasion. There is a sloughing in the epithelial. Maybe it's a small picture, not clear, but you can see injected conjunctiva and there is chemical irritation around the cornea. So these are for emergency. We should call the ophthalmology about it. Okay, let us talk about case number 3, acute angle occlusion glaucoma. Here in the hospital, I saw about 3 cases in emergency room for acute angle occlusion glaucoma within the last 2.5 years. So it's not common, it's very rare. Mostly the doctor call me, I come quickly, then I find it's open angle, it's not an emergency, and it's not angle occlusion. So let us differentiate between both of them. So the typical case, 65-year-old woman develops severe unilateral eye pain, and there is headache, blurry vision, colored halos, and vomiting. Mostly she said, I see halo around the light, and there is nausea, vomiting. This is critical. Patient come with pain, without nausea, without vomiting. Mostly it's not acute angle occlusion glaucoma, and it's mostly unilateral. This is another important thing. With severe headache, like a balloon will explode very soon. So the finding, you will have severe ocular pain, red eye, blurry vision, halo around the light, and severe headache. Mostly there is nausea and vomiting, and the pupil is mid-dilated. This is very important. So always check the pupil. It's round, regular response. Here it's dilated pupil, so it's not the normal size of the pupil. It's poorly reactive to the light. If you put the light, it's not constrict, and the cornea is hazy edematous. Now we will show pictures, and the anterior chamber, it's shallow. The GB message, I want to hear from him, this is not conjunctivitis. I need you to come to see this case. Immediate ophthalmology referral, and open angle glaucoma is not emergency case. Many cases come to emergency. I have a glaucoma since 20 years, 10 years, 15 years. This is not an emergency. This is normal open angle glaucoma. He will not come with nausea, vomiting, or severe injected photophobia, severe injected conjunctival photophobia, and severe headache. So look at this picture. This is acute angle occlusion glaucoma. First of all, the pupil. It's not the normal size of the pupil. You can see it's mid-dilated. Okay, so the eye mostly it's severe injected. Okay, if the eye is wide, this is not acute angle occlusion glaucoma, but it's in this picture, severe injected eye with mid-dilated pupil. Another thing, the cornea. The cornea is haze, edematous and hazy. Mostly he complain, I can't see. Okay, with severe injected eye, and the pain is very, very severe. And here there is another trick. There is cataract. Mostly I see maybe 2 or 3 cases they have cataract that lead to phacomorphic glaucoma. The cataract close the angle, and it will lead to phacomorphic acute angle occlusion glaucoma. So you see white lens like this. This is acute angle occlusion glaucoma. Okay, this is another picture, both of them acute angle, mid-dilated pupil, severe injected around the cornea, call it ciliary injection, and edematous hazy cornea. And here in the second picture, you can see the haziness of the cornea, mid-dilated pupil, severe injected eye, and this patient come with nausea, vomiting, severe headache, and it's unilateral. This is acute angle occlusion glaucoma until proven otherwise. The anterior chamber is shallow here, but for emergency doctor, I will not ask about anterior chamber shallow or not. It may be difficult for you to know at this stage. Okay, case number 4, the corneal ulcer, the infectious keratitis, especially the patient come with contact lens wearer. Mostly when they call me for contact lens wearer, I always think about 2 things. It's abrasion, corneal abrasion, or it's corneal ulcer. So the patient come with painful red eye, photophobia, decreased vision. If I put a fluorescein, you will see the corneal epithelial defect. You will see stromal infiltrate. This is not for youth, for ophthalmology. And you should think about microbial keratitis. Contact lens wearer is a major risk factor. We will see some picture and we will know more. What is the red flags? If there is pain, photophobia, reduced vision, corneal opacity, corneal infiltrate, there is anterior chamber reaction. Sometimes you will see the hypopyon. This is significant picture. And contact lens use. Okay, for GB action, what you tell the patient, first of all, stop using contact lens. This is very important. Don't give any topical steroid for the patient to an undiagnosed infectious corneal ulcer. Referral urgent same-day ophthalmology. Let us see some pictures. So mostly when you talk about infectious keratitis or corneal keratitis, I want to know if it's central and if it's large or it's only at the periphery and small, and it come with injected eye or not. So infectious keratitis, the most important, if it's central and large and affected the vision, here it's an emergency case. Okay, so you should refer it as soon as possible to ophthalmology. And if it's only peripheral corneal ulcer and the eye is not injected and there is no pain, sometimes it's autoimmune corneal ulcer other than infectious, and he can wait to the next day. But this picture, central, large, severe injected eye, severe pain, photophobia, can see this is mostly infectious keratitis until proven otherwise, especially if come with this picture. Okay, here is another corneal ulcer, paracentral with ciliary injection around the eye, and here we should call the ophthalmology. Now, case number 5, the corneal foreign body. Especially the patient will come as mechanic or a worker, and he work especially in the metal. He developed foreign body sensation after grinding the metal. The GB assessment, you should first check the visual acuity as we talk, counting finger, hand motion. You should look at the cornea. If you can, evade the upper lid and look if there is any foreign body under the eyelid, and consider the mechanism of the foreign body entering the eye carefully. If you look at this picture, you will see it in the emergency at least every 2-3 days. I see a patient like this. This is here the metallic or the corneal foreign body. Okay, this is emergency but not urgent. If the patient come next day, within 48 hours, we should remove the foreign body. Some patient, they come after 5 days or 1 week. They don't have a blurry of vision. The foreign body is at the periphery, but they have red eye, and the red eye doesn't resolve. And they try to wash the eye daily, but it doesn't resolve. We should remove the foreign body. Can the GB doctor remove the foreign body? In 2 conditions. First of all, if you have eye drops, topical anesthesia eye drops, like ibuprofen, Binox, anything you have in your pharmacy, and you have a Q-tip, cotton bud tip. If you can remove it with a Q-tip, it can go very easily, especially after you anesthetize the eye. If you are hesitate, you can do it. Just refer it next day to the ophthalmology to remove it. Okay. Here another corneal foreign body at the periphery. Okay. Here you can look at the corneal foreign body, and mostly this is since many days, maybe 4 or 5 days, because you can see whitening around the foreign body, and this is whitening, we call it the infiltrate. So here there is keratitis starts to appear around the foreign body. Here also another foreign body, you can see the whitening around it due to the infiltrate, due to some inflammatory mechanism starting here. Okay, another case, traumatic hyphema. Typical case, young man is punched in the eye and develop a blunt in the anterior chamber. Please close your microphone. Okay, thank you. So here, anterior chamber, so it's a blood in the anterior chamber. And here, if you call me and you told me the grade of the hyphema, it's amazing thing. The grade in the hyphema, it's only 1/3 of the anterior chamber. We call it grade 1. If it's reached the pupil, okay, about half of the anterior chamber, this is a grade 2. More than half of the pupils, this is grade 3. And if it's total hyphema, we call it 8-pool hyphema. This is grade 4, and this is the top emergency. Any hyphema, this is an emergency and should call the ophthalmology as soon as possible. But what as GB you should know and what you shouldn't do. So first of all, you should eye shield the eye, transparent eye shield. Don't patch the eye, only eye shield. Head elevation. And here head elevation, I prefer to telling the GB doctor to tell the patient, please putting in semi-sitting position or elevate the head at least 2 below behind the head. This, it will try to help to absorb the blood inside the anterior chamber. Avoid any third-party trauma. Try to control the nausea, vomiting, and avoid any aspirin, non-steroidal anti-inflammatory drugs, especially for analgesia, because it increases bleeding, unless there is a compelling systemic reason and specialist advice, urgent ophthalmology referral, and it's at the same day. Here, another picture of hyphema, and this is grade 1. Case number 7, orbital cellulitis. This is very important, and we should differentiate between preseptal cellulitis and orbital cellulitis and other things. The typical case, a child come with fever and he has sinusitis, develop eyelid swelling. There is a proptosis and severe pain, especially when he movement his eye, and there is reduced vision. And how we distinguish preceptal cellulitis from orbital cellulitis? In a preceptal cellulitis, there is eyelid swelling, but there is no proptosis. And when the patient moves the eye, it's normal eye movement. There is normal visual acuity, and if we check the pupil, there is no relative afferent pupillary defect. In orbital cellulitis, it's the opposite. Mostly there is fever, there is systemic illness, there is a proptosis, there is pain when he moves the eye, restricted motility, there is diplopia, reduced vision, and if you check the pupil, there is relative afferent pupillary defect. Look at this picture here. This is common scenario of orbital cellulitis. Here, you tell the patient to look at the right side. You can see the right eye is not move at all. It's fixed in the center, but here the eye is movement. Okay, so restricted eye movement, this is orbital cellulitis. But if the eye is moved, you should think about preceptor cellulitis. The inflammation is anterior of the orbital septum. This is a preceptor cellulitis. But if it's behind the orbital septum, this is orbital cellulitis. Here in the CT scan, it's common complication come with orbital cellulitis, the subperiosteal abscess. So in orbital cellulitis, mostly there is sinusitis, and the most common sinusitis come with it is ethmoidal sinus infection, especially in children. There is fever, there is restricted eye motility, severe pain, injected eye, the vision, it will decrease, and the motility, it will decrease, restricted eye motility. All of these think about orbital cellulitis, and it's an urgent admission. The patient should admit it to the emergency department. But if there is movement and there is no decreased vision and there is no rapid, the pupil is response round regular, mostly this is a preceptal cellulitis, and you can manage it as outpatient, not inpatient. So the GB action require hospital admission for any orbital cellulitis, emergency department management. You should counsel the ENT doctor and the ophthalmology doctor to start IV antibiotic according to the protocol. Orbital imaging when indicated, and refer immediate to hospital admission. Call the ophthalmology and call the ENT doctor. Here in this picture, many doctors, they call me, doctor, I have orbital cellulitis case. And I come and I look at this picture. And when I look at this picture, it's totally not orbital cellulitis, even it's not a preceptal cellulitis. Okay. Doctor, anyone want to share what did he see and what did he think? Dr. Taqwa. Yes, Dr. Taqwa. What you see here? Dr. Taqwa opened his mic, but she didn't want to talk. Okay, Dr. Hiba, what did you see? Okay, so here you see upper and lower eyelid. Yes, upper and lower eyelid swelling. Okay, and when you see this, mostly this is angioedema, only swelling due to any allergic. Maybe she used makeup, she put some new cosmetic things to over her face or over her hair, and you see angioedema swelling. And if she open her eye, mostly you will see like this eye, white eye, normal pupillary response round regular and reactive, and there is no inflammation inside the eye, only eyelid swelling. Mostly this is angioedema, we call it, and it's not emergency at all. Within 48 hours, it will resolve. You can give oral antihistamine and go home. So this is not an emergency. So angioedema different from orbital cellulitis or preceptor cellulitis, especially if the eye is white, no reduce of vision, there is no painful in movement of the eye, the pupil reactive is very well. So this is angioedema, not an emergency case. Okay.
دكتور معلش
Yes.
الانجيو بتكون bilateral؟
It can come unilateral or bilateral. If she use her cosmetic for both eyes or around both eyes, it can come both eyes. Sometimes it come unilateral. Someone go to playing with animals like horses or cats. It's common. and he then rub one eye. So it come with one eye. And when we see on angioedema, bilateral, especially in old age, we should think about other things, systematic cause, like renal problem, nutritional problem, other thing. But mostly, if it's in one eye, it's due to an allergic reaction. It's not due to an severe problem inside the eye. And mostly this is outpatient clinic. I didn't see them. Please refer it to next day to the clinic. Mostly, actually, I finish my lecture, and I want to ask if there is any question. If there is no, I will start my questions.
Dr. Abdurrahman?
Yes, Dr. Handsome, please.
Assalamu alaikum, Doctor.
Wa alaikum assalam.
Okay, my question is this. Like now in ER, we don't have ophthalmoscope. No ophthalmoscope in ER. Some of these conditions, I thought we should at least visualize with ophthalmoscope before we can be able to come up with some of the diagnoses. We don't
Okay.
have. How do we do that? We can't just look at the patient eye. We are GP, we are not specialists. Then at least the basic tool to visualize the eye we don't even have. And then we begin to make impression. This can bring so many uncertainty for us.
Yes. Okay.
At least one ophthalmoscope should be provided in ER. Even
Yes.
otoscope we have now is not even functioning. It makes more difficult.
Yes. Okay. For this, actually, this is a very good question, and I hope that we will ask the administration to give us a new ophthalmoscope for emergency department. But the things that even with your torch light or mobile phone, you can see the inspection from outside. I will show some pictures now or some question, and even with your torch, you can see the problem. And if you are hesitate, you can take a photo and send it to the ophthalmology. And from one photo, I can diagnose the patient. 90% of the persons who come to the emergency, it's not an urgent case, most of them, but they can't understand the problem because they are didn't given like they didn't take a good counseling about the case. But case by case, you will learn how to counsel this patient. And the case you are hesitate, you can refer it in the same day if it's urgent, the cases that I talk about it in the first of the lecture. And if it's not urgent, he can come next day at the morning clinic. But let us continue look at this picture. And Handsome, this is your first case. If the patient come with this picture and he told you, my sister put her finger in my eye, what did you see? And from this history, what you can know? What did you see here?
I think it's a laceration or injury in the cornea,
Yes.
and I can see the iris. I think it's prolapse, right?
No. This is corneal abrasion.
My
Abrasion.
impression is corneal abrasion. I was speaking, but I didn't know my audio was off.
Yeah, okay. This is corneal abrasion. If you look at the corneal here, you can see sloughed epithelium. And this is very common scenario. You will see it every day in the emergency. And mostly the patient told you there is a toy enter inside my eye, my brother, my sister with her finger enter my eye, or my own finger. And you can see this is sloughing. They come with severe pain. And the type of pain here, it's like needle inside my eye. I have a needle stinging my eye. It's severe pain. Why it's severe pain? Because the cornea, the nerve ending at the cornea, it's 500 times more than the skin nerve ending. The most sensitive organ inside the body, it's our cornea. Very, very sensitive. So the most painful thing when someone have corneal abrasion. And when you put only one local anesthesia eye drop, the pain is relief. He open his eye, nothing. And the most important treatment in this case, I patch the eye, put eye ointment, but you have local antibiotic, gentamicin, fusidic acid, eye gel, and patch the eye. When he come next day, I remove the patching. Okay, mostly this cornea, it's healed because it's 500 end nerving more than the skin. They have very rapid epithelial regeneration. and the epithelium, it renew itself within 24 hours, even within 48 hours. So very quick healing in the cornea. So when you patch, you didn't let the eyelid rub the cornea, and the cornea, it will heal within 1 or 2 days. So always, I patch the eye, please don't give any treatment except eye ointment, and tell the patient, don't use any eye drop, don't use any ointment, don't use anything. Just come back next day to the ophthalmology. He will remove the patch and he will assess the cornea. Okay, this is another case.
With this case, what complication can happen to the patient?
Cornea
operation.
Which complication can happen? Mostly, if you patch the eye and you give antibiotic, you save the eye. The antibiotic, the ointment, it will work within 12 hours to 24 hours. So it will prevent any infection. And when you close the eye, the antibiotic is still there. And this ointment is still inside the eye 12 to 24 hours. So you will protect the eye from any infection. And when you patch, you just like activate the healing process of the epithelial cells of the cornea. The other things, if you didn't patch the eye, what will happen? And he use eye drops. The eyelid still rub the cornea. The most problem with the corneal abrasion, the eyelid still rub the cornea, and this rubbing, it will increase the abrasion. When I close the eye, the eyelid, it doesn't rub the cornea, so the cornea, it will heal. But if he's still blinking, there is no healing. So I like to patch. Sometimes 48 hours I patch the eye. So I stop the blinking effect. And this blinking always is scratching the cornea again and again. So I want the eyelid just to close. Don't blink a lot. This is the most important thing. Here another case. This is another corneal abrasion.
دكتور معلش
Yes.
بس same case. If patient is still complaining photophobia, this indicates there is some problem
Every corneal abrasion come with photophobia. Because
after مثلا 3 weeks or 4 weeks still there is photophobia when he exposed to sun there is an intolerance to sunlight.
Photophobia, it's like a common name or a common like a problem. Not everyone have corneal abrasion, he will have photophobia, and even versus. Like photophobia, anyone have a dry eye, he will have photophobia. Anyone he have allergic conjunctivitis, he will have photophobia. So photophobia, because if we come back, how the patient see, or everyone, how is see, the light, it's come at the tear film over the cornea, and this tear film, when the light, it just reflect at this tear film, it will reflect to the retina. So if the tear film disturbance happened due to anything, if you use your mobile for hours, 3-4 hours without using lubricant eye drops, you will have photophobia. If you have a dry eye, if you didn't sleep well, you will have photophobia. So photophobia, it's not a major problem. Anyone can have photophobia. Just use your mobile, then go to the sun, then you will have photophobia. So for me, when someone say I have photophobia, it's emergency, come to see it. It's not emergency. I see sometimes photophobia. Photophobia mean there is abnormal sensation to the light. I can't open my eye, especially when there is light. I have high sensitivity to the light. Any dryness in the eye can lead to photophobia. And when there is corneal abrasion, sometimes the dryness increase in these patients. So always they have a dry eye. So they need more lubricant because they have photophobia or other thing. This is another case of corneal abrasion. Here the epithelium is sloughing. Okay, the epithelium sloughing, and you can see the injected eye. And here also we should patch the eye and come next day to the eye clinic. Okay. Doctor who talked, Dr. Taqwa, or who asked me the last question? What did you see in this case? Anyone can answer.
Blepharitis.
Okay, who's talking?
Blepharitis.
Okay, doctor. Okay, this is a case of blepharitis. Yes, it's very common. This is not an emergent or urgent case. Mostly the meibomian gland, the lipid gland are closed, and it leads to severe blepharitis. He needs to clean his eyelid. Okay, with warm water, we can give him eye ointment like fusidic acid eye gel or gentamicin. he can come to the clinic after 2 or 3 days. It's not an urgent case. The doctor should come to see this patient as soon as possible. This is an outpatient clinic. He can come to the clinic later on. You will see a lot of blepharitis in the emergency room. Okay. Another case. What did you see here?
Chalazion.
Yes, chalazion. Also, this is very common. It will come to emergency. The chalazion mostly, it's like a slowly progressive thing. Mostly it take 2 weeks, 3 weeks, sometimes 1 month until it come with this shape. Sometimes it come within days, but my meibomian gland, it closed, and after it closed, the lipid is still inside the meibomian gland. Please, just anyone just open the mic, close it. Okay. So chalazion or hordeolum. The difference, the chalazion, it's chronic. The hordeolum, it's acute. It come within days. Both of them due to meibomian gland closed, and there is lipid inside this meibomian gland, and sometimes come with severe pain. The bacteria always love the lipid. So the lipid, it's a good environment for this bacterial to growth. So this is why we see this infectious and pain. And this is not emergency. He can use hot compressors, and he can use tea compressors or baboonish compressors. Why tea and baboonish? Because it's antiseptic. It kills the bacteria inside these meibomian gland. So I prefer to tell the patient use tea compressors 3 times a day, and you can use eye ointment inside the eye, Tubradix, Maxitrol, or even pure antibiotic like fusidic acid or gentamicin, and come to the clinic later on. If it doesn't resolve, mostly I will go for surgery to remove it. But this is an outpatient clinic, and he can come after 1 week or 2 weeks after he uses his treatment with the eye ointment and the hot compressors. This is another case of bilateral chalazion. You can see the eyelid swelling, okay, in both eyes due to the chalazion. Okay. Another case. What did you see here? Doctor.
This is chemosis.
Yes,
Chemosis.
yes. It's a case of conjunctival chemosis, conjunctival swelling. Okay, for me, this is not an urgent case, emergency case. Any allergic reaction can lead to this conjunctiva to swell, and the water bulge the conjunctiva forward. So any allergic reaction can lead to conjunctival swelling or chemosis, especially when the children play with dust, play with gardens, play with animals, when they go to the horses or something. Mostly the family come very afraid and fear from the shape of the eye. It's something you should counseling the patient. This is something not urgent. Just relax. Only swelling in the conjunctiva, some water bulging the conjunctiva due to the allergic reaction. If you give him lubricant eye drops, antihistamine eye drops like Olubat, Olopatadine, and come to the clinic after 1 or 2 days, it will resolve mostly within 2-3 days. Okay, so it's not something urgent. Another thing, what did you see here?
It's also chemosis, right?
Yes, chemosis. Is it urgent, Dr. Hadil?
I don't think so.
Yes. So you can see this lecture. So when someone tell me conjunctival chemosis and the swelling of the conjunctiva, I don't care. Actually, I don't care. I said, okay, tell the patient come next day. I will not come to see this patient. For the family and the patient, it's something like scary, and he is so afraid. But for me, it's something normal. Look, the cornea is clear, only fluid under the conjunctiva, and it's push it out. For me, it's only chemosis. Chemosis, mostly allergic reaction. For me, it's not an urgent, not emergency. I can see it in the clinic. Sometimes the patient come like this, or another chemosis. Look, it like severe swelling. But if the patient come next day to the clinic, I will see him normal. There is no any swelling. It will disappear within 24 hours. This scary shape, next day come to the clinic without chemosis. Okay, so For me, only conjunctival swelling, chemosis, because many patients come with this picture. The emergency call even at 1 a.m., 3 a.m. coming quickly. I only saw only chemosis and it's nothing here. Dr. Handsome, what is this? I just want to be sure if he is with us or not.
Hello?
Yeah, what did you see here?
I'm seeing this still ecchymosis also, some conjunctival.
Yes, this is conjunctival
edema.
chemosis. You can give him
Yeah.
olopathy eye drops, lubricant, and come next day to the clinic. Okay. Mostly there is allergic history, playing with dust, playing in the garden, he playing with horses, playing with a cat, playing with bears. So mostly there is a history of allergic. So he will come with chemosis. Okay, what did you see here, Doctor?
معلش
Yes.
دكتور اللبات اي دروب نفسها النفازولين اللي عندنا في الطوارئ.
No, olopatadine. Olopatadine. If you write olopatadine, it will appear in the system. Olopatadine, mast cell stabilizer. Okay. Okay, doctor, what did you see here? Dr. Ruwaida, or who is with me? Yes. What did you see in this picture? Next one. This one.
Subconjunctival hemorrhage.
Yes,
Subconjunctival
subconjunctival hemorrhage. It can come like this, small. It can come like this, can come like this, mostly one side. Okay. And this is for me not emergency. Some always the patient come very scary, afraid. For me, it come alone and it will resolve alone. What is the subconjunctival hemorrhage? There is a small capillary and it's exposed, and this dot hemorrhage, it just spread all over under the conjunctiva. And this subconjunctival hemorrhage, it will increase within the 2-3 days. It can start like this small dot, then come after 2 days like this. It's okay. Then it will decrease like this, then it will come back like this until it disappears. So don't afraid if it's increased. Tell the patient it take 2 weeks till 3 weeks. You can give him all lubricant eye drops just for psychiatric support. It will do nothing, the lubricant, but the patient, I need treatment. Okay, take this lubricant eye drops. Actually, it doesn't need any treatment. It will resolve within 2-3 weeks. If you want to make like next step or something for the patient to make him more relaxed, do for him CBC, BT-INR. 90% of the patient, it will be normal. Check the blood pressure, but most of the patient, I saw them normal, but you can relax him, take the blood pressure, check the CBC, BT-INR. Mostly it's normal. It's a small capillaries exposed due to any stress, sudden stress. Patient can come with constipation and he have subconjunctival hemorrhage. He have severe asthma with severe cough, he can come with subconjunctival hemorrhage. He just shouting, especially a teacher or something, person with a worker or something, he can come with subconjunctival hemorrhage. So any stressful effort, or he just handle like a gas bottle or something heavy, just lifting heavy object, he can come with subconjunctival hemorrhage. Especially patient if he has hypertensive diabetes, it's more common with them, or especially patient they have bleeding disorder, it's more common with them than other. Okay, this is another case, and you can, it's outpatient clinic. You can give him appointment after 2-3 days, 5 days. It's not something urgent at all. He can come later on. What did you see here?
Dragon.
Yes, pterygium. Pterygium also, it's not an emergency. It's longer process. It come within years, and that this pterygium reach the cornea, and mostly it needs surgical intervention when the patient want, especially if it's reached the cornea. So it's not emergency case. It's also an outpatient clinic. So for these two picture, which case you should call ophthalmologist to come to see it? Picture number 1 or picture number 2? Who want to answer?
The first picture.
Which one the first? With this one or this one?
Number 1, yeah.
This is number 1, this is number 2. Tell me, number 1 or 2?
Number 1.
Number 1. Anyone else?
Number 1.
Number 1. Who else?
Number 1.
Yes, so number one. Number one mean infectious keratitis. Ophthalmology should see it. Here it's chemosis. Chemosis due to any allergic. It's not an emergency. Okay, I'm happy because you are focused with me at the lecture. Okay, so I will just summarize. So each GB doctor, emergency doctor, should check the visual acuity if it's reduced or not. He's seeing counting finger or hand motion. If there is pain, severe, and you can just say from 1 to 10 how much the pain. Is there is any trauma, especially chemical exposure, if the pupil abnormal, if there is rapid, and I show the slide about the rapid, and I will repeat it if it's not clear, if there is any corneal ulcer or obesity, and if there is any proptosis, painful, restricted eye movement, if there is any recent surgery or intravitreal injection, and I make the step 8 flashes, floater, curtain. Why this is important? Ask about if you see floaters, flashes of light, or curtain come to in front of his eye. Anyone? Flashes, floaters, and
The retinal
Detachment.
Detachment.
yes, retinal detachment, or sometimes peripheral retinal detachment or central retinal detachment, whichever. So if the patient just complain of only floaters, this is not emergency. Sometimes they call me the patient come with the floaters. Floaters may be physiological vitreous changes. But if this floaters with severe flashes of light, and this flashes of light is continuous, but if the patient say the flashes of light come one time per day, this is not emergency. But if see I saw the flashes of light since hours and it doesn't disappear, this is emergency. Or if he see I see the floaters with curtain-like appearance in front of my eye, this is emergency. Floaters alone, not emergency. Floaters with continuously flashes, this is emergency. Floaters with curtain-like appearance, this is emergency. So this is very important. And thank you all. Any questions?
Dr. Ali,
Yes.
you said if only floaters, it's not an emergency,
Yes.
right?
Floaters, it's a physiological changes in the vitreous. Everyone see floaters. Even me, I saw floaters. If you just sit down in front of a white wall or go outside in the morning and you look at the sun, you will see the floaters. Everyone will see these floaters. Everyone have these physiological changes in his vitreous. Vitreous, it will syneresis and liquefied, then it come down at the bottom of the eye, and the eye, it will make a new vitreous. So everyone have a floaters. This is normal physiological changes. But if floaters with the flashes of light, and this flashes is continuously, it doesn't stop, this is an emergency. Or floaters with curtain-like appearance, this is an emergency. I have a problem sometimes. The doctor said me the patient come with sudden loss of vision. And when I come, I find he need glasses. There is difference between sudden loss of vision and gradual decrease of vision or blurry of vision. So always check the visual acuity by your finger, by your hand motion, by your light. If you can see the light or not, then you can see my hand movement or not. If you see the finger or not. So I can judge this is loss of vision or only gradual decrease of vision or blurry of vision. Anyone have any questions?
Okay, one more question, just one more.
Yeah.
You see, one of the challenges we have in ER, like some of these conditions you mentioned, pterygium, chalazion, retinal detachment, subconjunctival hemorrhage, these are things we see on regular basis. But the issues with these patients, they are very impatient and anxious. When they come, they say, blood is in my eye. I want eye doctor now, not later, now. Don't tell me tomorrow. They are so anxious, and you try to tell them, look,
sometimes
this is not a serious emergency, and we assure you that it's not going to go terribly bad. First thing tomorrow morning, you could have appointment to see the doctor. Most of them don't want to hear. They tell you that my eye will go blind. I don't think I'm comfortable with your explanation, and they want to get the ophthalmologist right there and then. And this is the reason that most of the calls
Okay,
Most
so
of the calls with emergency that the patient is here and wants to see eye doctor. You know, this is the problem.
yes, I
Sometimes they don't
understand. Yes, I understand. Let me explain to you. First of all, the patient always he want the most consultant senior doctor to see his very mild problem. First of all, if he is in the British or European country, no one will come to see him, and there is categories to ophthalmology to come to see the patient. I know this is not happened here, and it's different scenario. But first of all, sometimes you don't have ophthalmologist on the schedule. There is no eye doctor. So this is the first issue. The second issue, sometimes you are in very far periphery area. There is no any eye doctor around you. So first of all, the patient who should understand I am an emergency doctor and I know this case and I should show the confidence of myself in front of this patient. And he should know there is no ophthalmology available now. And this case, it's only subconjunctival, not urgent. There is no surgical intervention. There is no not important thing to call consultant to come to see this case. It's something we see it every day. If the patient hear these things, sometimes they understand. Other, they ask to call, please call the eye doctor and let him talk with me. The other of them, they said, okay, I will come next day to the eye clinic. Please give me appointment next day. So depend on the situation of the patient. But if it's an urgent, for me, if you call me, I will not come to see subconjunctival hemorrhage or chalazion or conjunctival chemosis. But if you call me for chemical injury or rupture globe or hyphema or orbital cellulitis, I will come within 10-15 minutes. I should be there. So for me, according to the history, your examination, the scenario, it will me judge. Even the patient, if he go and do complain, for me it's okay, do complain, no problem. You only have subconjunctival hemorrhage, it will resolve within 2 weeks. The complaint, it will not do anything for me or for the emergency doctor. Sometimes the patient have only allergic conjunctivitis and the emergency doctor call me, the patient, he want to make complaint. I said, okay, please give him the number of medical director and let him do complaint, no problem. Because this complaint, it will not reach to any place because only he have allergic conjunctivitis. It will resolve within 2-3 days and he will forget what did he have before 3 days. So not every complaint, they will take it seriously if it's not a real complaint. If it's a real complaint, it's different. But as you are emergency doctor or GP doctor, you should know this is an urgent case or it's a minor case or it's a moderate case. And this complaint, it's very important or not. So for me, if he have conjunctival chemosis and he will want to make complaint, no problem, go and make complaint. I don't care. It's normal case for me. It's not an emergency case. Do what you think. I work in many places. I work in many places. Always they call me for rupture globe just to come to do the surgeries. But now it's different situation. So I try to advise and the residents, the emergency doctor, and just guide the patient. Always you are the doctor. You catch the steering, not him. But make good counseling and he will understand. If he didn't understand, with very good counseling, go and make complaint, no problem. Okay, be confident of yourself. Any questions?
Thank you, doctor.
Welcome. Welcome, Dr. Hansen. Dr. Abdurrahman, is there any question? Is it clear?
No, Dr. Abdurrahman, everything is clear.
Dr. Musab? Dr. Musab is here. Okay, last question about rapid. Is it relative afferent pupillary defect clear? How you check the relative afferent pupillary defect?
By the light, reaction to the light, and accommodation, reflex.
Yes, when you put the light, you will see both pupil constrict, okay, round, regular, and response to the light, the pupil will contract. But if you put the light and the pupil dilate, if the pupil dilate, this is an emergency and you should call me. If it's constrict, this is normal response to the light. Thank you all. Thank you so much. I hope it's clear. And inshallah,
Thank you,
we will
Dr.
make
Abdullah.
more lectures later on, inshallah, and it will be recorded for anyone need it. I will send the link for him.
Thank you. Thank you so much. Thank you.
Thank you. Thank you so
Thank you,
much.
Dr.
Thank you.
Ali. Thank you, Dr. Abdurrahman.
Thank you. Thank you.
Thank
It's
you.
my pleasure.